Good afternoon. It's my pleasure to introduce you to Dr. Dawn Ehde. Dr. Ehde is a clinical psychologist and holds the Nancy and Buster Alvord Endowed Professorship in Multiple Sclerosis Research in the Department of Rehabilitation Medicine, University of Washington School of Medicine. Through research funded by the NIH, PCORI, the National MS Society, and Leidler, she has conducted multiple randomized controlled trials evaluating behavioral, pharmacologic, and physical activity interventions for pain, fatigue, and mood in persons with chronic neurologic conditions. She's especially interested in improving access to evidence-based pain care via telehealth and integrating non-pharmacologic interventions for chronic pain into healthcare. She serves as the editor-in-chief for the journal Rehabilitation Psychology and is an editorial board member for Archives of Physical Medicine and Rehabilitation. Dr. Ehde is our 2020 Neidler Invited Lecturer for the RRTC on Employment of Persons with Physical Disabilities. Please welcome Dr. Ehde.
Well, thank you. Hello, everyone. It's strange to be giving a lecture to a bunch of boxes, although I'm sure most of us have done this by now, but I'm nonetheless delighted to be here. I want to thank my collaborators at Shirley Ryan as well as at the University of Washington for partnering with me in the work that I'll be describing today. I also want to thank all of you attendees for coming today. I know many of us are getting zoomed out or get a little bit of Zoom fatigue, so I hope to make this interesting and relevant to your practice and research to make it worth yet another Zoom meeting. So today what I plan to do first is I'm going to first just describe why we'd be interested in telehealth for chronic pain care. I'm going to talk then more specifically about cognitive behavioral telehealth interventions for pain. In doing so, I'm going to describe a few different studies that we've conducted here at the University of Washington, as well as the study that's part of our employment RRTC that we're just getting started, and that you may have patients or people you know who could potentially participate. And then I'm going to finish up by talking about best practices for delivering interventions via telehealth, both for individual and group video conference delivery. I hope to save some time definitely to talk about this because I think it's something that's all really on the forefront of most of our lives right now, especially if you're a clinician providing care. Much of it is being delivered in many places via telemedicine. So I'm going to talk about that as well. First, I want to just describe some terminology. You may hear the word telemedicine, you may hear the word telehealth, telerehab, telepsychology, tele-PT. There's all sorts of words that we use to describe the use of technology. And so I wanted to give you just a definition for telehealth. Really, telehealth is technology-enabled healthcare that involves both care management and delivery systems that really expand and extend capacity and access. And that's the definition per the American Telehealth Association. And so telehealth is really the kind of the catch-all category, at least by their definition, with telemedicine and telerehab being, components of that. You may hear me at times interchangeably use the terms. I think whenever I'm talking today, I'm talking about the use of technology to provide access to healthcare. Now, telehealth can include a lot of things. So it can include, at its most basic, delivering care via phone in real time or synchronous. It can involve live video conferencing, both with groups of individuals as well as one-on-one, also in live time. But there's a lot of other interesting ways technology is being leveraged to deliver care. So there's store and forward or asynchronous. One example of that here at the University of Washington is some of our surgeons have developed an app where post-surgical wounds are evaluated by sending the patient home after their surgery with kind of instructions in the app, and then they can upload photos of their wound as it's healing to help their providers know who should come in for a wound check and whose wound appears to be healing fine and doesn't need that. So that's an example of store and forward, because the physicians look at it at, kind of when they have time to sit down and do that, not in real time. That's also remote patient monitoring. Certainly there's a lot of interest in using apps or mobile health and web-based e-health, which we've started to do a little bit of work in. And there's even been some work in pain looking at interactive voice response technology, where you call a phone number, depending on what your pain rating is, you put in, maybe you rate your pain a 7, so you punch number 7 into the phone, and then you get back some information about what to do to manage your pain. And so it's a series of prompts that surprisingly people seem to enjoy and seem to benefit from. So there's really a lot of ways we can leverage technology in today's world. I'm going to be speaking mostly about telephone delivery because that's where we really started our work and what we'll be doing in our current project, and then also a little bit about live video conferencing. Now, I wish I could claim that telehealth was something that I started or invented, but really it's been around a lot longer than just since the COVID-19 pandemic started. Way back I think this was published in 2005, so way back almost 15, 20 years ago, Dr. David Moore, who's a psychologist at Northwestern at the Center for Behavioral Information Technologies, or Behavioral Intervention Technologies, way back then, he decided to leverage the telephone to try to improve access to cognitive behavioral therapy for major depressive disorder in persons with multiple sclerosis, or MS. And as you may know, many people with chronic neurologic conditions like MS have high rates of depressive disorders. And so he tested the efficacy of a 16-week telephone-delivered CBT, cognitive behavioral therapy, against a control condition where participants got the same number of sessions and got access to a therapist. It was more of a supportive psychotherapy. And he found that, first of all, people really adhered to the treatment. Less than 6% of participants dropped out of treatment, which is an incredible rate, especially when you're talking people with depression. He also found that those in the telephone delivered group had good outcomes. Their depression remitted, and it was better than usual care. So this was really a pioneering study that influenced a lot of the work that came after it, including in the area of pain. Now, pain and depression, however, are not the only places people have been using technology. And just to give you a flavor of what's going on in the rehabilitation science area, this is just a systematic review and meta-analysis that was published looking at technology-based remote physical rehab interventions on physical and their effects on physical activity, including walking in people with MS. And they showed in this systematic review that technology-based distant or remote physical rehab improved physical activity among people with MS. So again, I think many of you probably even know of a wide range of practices that are starting to become more commonplace, even pre-pandemic, but certainly since the pandemic. So you might wonder why I became interested in telehealth, beyond just the influence of some of that seminal work by Dr. David Moore. Working and living in Seattle presents a number of challenges to many of the people we serve through our rehabilitation medicine clinics. I'm a psychologist. I practice clinical psychology in a neuro rehab clinic, in an outpatient neuro rehab clinic as part of our level 1 trauma center. So lots of people with pain, lots of people with mood disorders. And interestingly, our hospital is the only level 1 trauma center in a 5-state region. So we get people from all over, including what we call the WWAMI, Wyoming, Alaska, Montana, Idaho, and Washington. So that's one reason, for us to think about telehealth. Well, Seattle also has the worst traffic on earth, according to this headline from 2018. So, certainly that's another reason. Many of our patients, even those who don't live that far in terms of distance, find it very onerous or challenging, or find barriers to getting in for care. And then anytime we have a snowstorm, of course, in Seattle, the city shuts down. And so that's, although it's infrequent, it's also another reason why telehealth can overcome some of these barriers. And unfortunately, the COVID-19 pandemic has also left most of us considering telehealth, some for the first time, in the delivery of a wide range of healthcare in our healthcare systems to try to mitigate and prevent the additional exposures to the virus. Well, so why telehealth specifically for chronic pain? And that's the area I'm particularly interested in, is how can we help people who live with chronic pain and a physical disability access pain care? Well, unfortunately, still to this date, kind of our frontline treatment tends to be medications, and not that medications for pain are good or bad, but we know that we need to be mindful of opioids and all the problems that have come with the opioid pandemic. We also know that there's just not a lot of, there's many pain conditions which are not alleviated fully by medications. And so certainly, as you know, as rehabilitation professionals, really a broader biopsychosocial approach to pain management is really considered the kind of the optimal care. And as part of that, psychological interventions, unfortunately, however, although recommended, are often underutilized. So many people, and there have been a number of studies that have shown many people with chronic pain and physical disability do not have access. Something like, I think the most recent surveys I saw, fewer than 10 to 15% of people with spinal cord injury or amputation or TBI actually have access to behaviorally based, evidence-based psychological interventions. Just to step into this just a bit deeper for just a moment, you know, why would I care about this? Well, not just because I'm a psychologist, but also because we know psychological pain interventions work. They help people. Although the effect sizes can be modest, they're still comparable to or better than many of our frontline medical interventions, including medications. And there's considerable individual variability in treatment response. There are certainly a number of people that do quite well with psychological interventions, just like certain people do quite well with other rehabilitation interventions. And so, you know, these people are missing out on the opportunity to improve when they don't have access to pain care. And really right now, the pain field, if you look at pain research in general, it's really accepted based on multiple meta-analytic reviews that these interventions work. And so where the field has turned its focus is not on efficacy, but rather on really trying to learn how to better tailor, streamline, improve, or combine treatments, as well as improve access. And so, you know, again, here's an opportunity to potentially use telehealth to help people access pain care. And just to highlight, if I haven't already, why I'm passionate about this area and why I think it's important for rehab professionals to pay attention is that the National Academies came out with a consensus statement in 2017 about pain management in the opioid epidemic. And they reviewed the evidence and came out with some pretty strong statements supporting this idea of non-pharmacological interventions. And they talk about this, and I have one quote from their report. It says, "Non-pharmacologic interventions for pain treatment, including acupuncture, physical therapy, exercise, CBT, and mindfulness meditation, represent powerful tools in the management of chronic pain. They may provide effective pain relief for many patients in place of or in combination with pharmacologic approaches." So really, based on you know, this need that we saw both clinically as well as in conducting in-person research, we would often find that people would want to be in our research studies. They would want to participate in studies of pain treatments. But then when they found out they had to drive up into Harborview or UW-Medicine, park, you know, or take a bus or arrange transportation through Access, they found it pretty onerous, or just some simply couldn't afford it or couldn't get there. You know, again, we draw from people all over Washington state. And so, you know, that really led us to deciding, based on input from stakeholders, that we needed to be looking at telehealth as a means to deliver pain care. And I have to say, I'm not alone in this at UW-Medicine. A number of my colleagues really have been conducting telehealth research in a wide variety of areas for the past 10 years. And that includes chronic pain, it includes treating depression, fatigue management, multi-symptom management, and in physical activity. And my colleagues and I recently added up, I think we figured out, even just through our treatment studies alone, we've treated more than 1,300 adults in our that have rehabilitation conditions using telehealth in the past 10 years. And this includes work done by my colleagues, Dr. Jeannie Hoffman, Dr. Mark Jensen, and Dr. Charles Bombardier. So now I want to just describe to you, to see how we've used telehealth, I'm going to briefly describe 3 studies. And I'm not going to get into a lot of details about the specific study design, about the specific results. What I want to do is really highlight how we leveraged technology to study different kinds of treatment. So we were interested not only in the technology or telehealth side of the research, but also whether these interventions are helpful to people. And so the first study I'm going to mention is the Take Charge of Multiple Sclerosis study, or Take Charge of My MS study. This was a randomized controlled trial, efficacy trial, where we compared people who had either chronic pain, chronic fatigue, and or moderate or greater depressive symptoms, or mild to moderate depressive symptoms in people with MS or multiple sclerosis. And it was a single center randomized trial where people were assigned either to a telehealth cognitive behavioral self-management program, or they were randomized to a kind of an education component that was also delivered by phone. So it was 2 telehealth treatments going head-to-head against one another. The interventions themselves were delivered by phone, one-on-one, in 45 to 60-minute sessions. And again, it was really developed to be a flexible treatment. We utilized a manual and a participant workbook, but people would learn different strategies like relaxation training or cognitive restructuring or pacing, and would learn how to apply that to whatever their issue was. And the reality is, many of our participants, as is true in caring for people with MS, many of them have multiple symptoms. Very few just have pain or just have fatigue. So really kind of this multi-symptom management. And the treatments were delivered either by doctoral level psychologists or master's level social workers. And we found in this study that 47% of those who received the cognitive behavioral therapy delivered by telephone had a clinically meaningful change in pain intensity. And in the pain field, clinically meaningful change is when a person has at least a 30% reduction in pain interference or pain intensity from baseline to the outcome point. And what we found, not only that people had a nice size, had a clinically meaningful change, but that these changes were maintained over time. And in the pain field or pain research field, 47% is actually a robust number of people to have a change, because unfortunately pain is very difficult to treat, and having 47% who get better, who have a meaningful change, is considered a good outcome. Certainly suggests we have more work to do, but it's still a good outcome. What I want to highlight for you are some of the feasibility or acceptability data, because this was really the first telephone-based or telehealth-based study that I led, and we weren't really sure how it was going to go. We weren't sure if people would adhere, if people would like the phone, if they'd treat it casually and not be there when they were at their scheduled time. Well, we found quite the opposite. We found that treatment adherence was quite high. 86% of our sample completed 7 or 8 of the 8 sessions, which is unheard of in our clinic. I mean, even with people who really want to come in and work on their symptom management, it's hard to make that many sessions, given the many barriers that can be experienced. They stayed on the phone a long time. Sessions lasted actually 61.5 plus or minus 10 minutes or so on average. So they were really engaging with the sessions. We also found that treatment satisfaction was very, very high, and that working alliance was high. And by working alliance, what I'm referring to is the therapeutic relationship or rapport that was established between the participant and the therapist. And when we did this study, there was a lot of talk and a little bit of skepticism, or I should say a little skepticism, even among our team, as well as people we would talk to and in the field, that you could establish a good relationship just simply through the telephone. But in fact, we found that we could, and that people were able to really, or at least they self-reported that they rated their alliance with their therapist as something very productive and very high. And then, not surprisingly, Dr. David Moore and his colleagues, they actually looked at this issue as well in a follow-up to the study I mentioned before, their telephone treatment for depression, and they found that that indeed they also found that therapeutic alliance was high for people. And this was actually, this was a study where, they compared face-to-face and telephone administered CBT for depression. And they found that they were pretty comparable in terms of therapeutic alliance. Another question that often comes up when doing telehealth is whether people with cognitive impairment, or at least subjective cognitive problems, things like difficulties with attention or memory, or organization, executive functioning, whether they can benefit from treatment. And so we decided to do a follow-up analysis of our Take Charge study to look at moderators of treatment outcomes, not only to look at cognitive moderators, but also to see if there were other baseline factors that would predict who would benefit from the treatments. And I think relevant to our discussion today, we found that the treatments were beneficial regardless of their baseline biopsychosocial characteristics. So regardless of kind of some, severity of MS, regardless of severity of pain, depression level at baseline, age, sex, as well as perceived cognitive impairment, people seem to do equally, they seem to do well regardless of kind of those baseline levels if they improved. So with that, we decided then to look at another way to use telehealth, to leverage telehealth to deliver pain care. And we decided to look at that in the context of integrative health, integrative care. Probably many of you are well aware that there's been a movement in primary care as well as in some specialty centers to really use integrative care where behavioral health is integrated into the care team of people in what, for example, in primary care. And one of the main models for this is something called collaborative care. I'm not going to spend a lot of time talking about that today. I want to talk more about how we leverage telehealth in this. But what we did is we had a randomized controlled trial looking at trying to improve the quality of depression and pain care in our MS specialty clinic using collaborative care. And we called this the MS Care Trial. And we did this in part because in some of our qualitative work and our work talking with our stakeholders who advise us and guide us on our research, we were talking with them, why do people, even when they live close by and we help them get in to see us by problem-solving transportation, why do they still underuse, or why do we, I don't mean to place the blame on them because I don't think that's often the issue, but why is there this gap? Why are they not getting this care? And this is some of the things that we heard in talking with people. These themes kind of came up over and over, just that, managing MS is confusing. There's a lot of things they have to do. One person said, I know from my doctor that there are treatments for mood and pain, but it's hard to get connected to them in a way that works for me. Another said, when I was depressed, my doctor recommended I see a therapist, but I never followed up. Why? It seemed too difficult. I wasn't sure where to start. And then one person said, I'm lucky because my wife is a therapist, so she acts as my case manager and helps me navigate the system. Most MS patients don't have this luxury. And so we decided to look at using, through a randomized controlled effectiveness trial, looking at collaborative care versus usual care in our MS center. And this is kind of a busy slide, and I'm not going to go over it in any detail. But essentially what collaborative care does is it plants a care manager, in our case, a social worker with behavioral health skills and training, and has them really become part of the care team in the MS Center. And so rather than a model where patients are referred by their providers to a psychologist or social worker or physical therapist, we have a care manager who routinely has a panel of patients that they follow and work with and do a lot of outreach to. And as part of that outreach, in addition to trying to catch people who fall between the cracks in terms of our care, they also provide behaviorally based, either in-person or telephone behavioral health care, cognitive behavioral therapy care specifically for pain and or mood. And so in this study, people were either randomized to receive usual care, kind of using our specialty center, which has a very robust interdisciplinary, expert level MS care, and compare it to collaborative care, which you see here in the purple, which also includes an embedded social worker to really enhance the care. And so in this trial, we randomized 195 participants. We're just about to submit our primary trial results, but these results are public because they're published on PCORI's website that I'm sharing with you. Here you see the state of Washington. I want to talk specifically about the reach of MS care. So what you see here are the various counties, and this is King County, where Seattle's based out of. So the darker the blue, the more people we received. But as you can see, we hit a lot of our counties. Some of these counties are not very populated, and they're so that's why they're in gray. We also had a few patients or participants from Alaska, Wyoming, Idaho, California, and Montana. So we gave in this study people the choice. They could either see the care manager in person, or they could see them they could have their care delivered by phone, or some combination. And we tracked what they chose. And we found that, there were a number of people, about half, 52%, who wanted some combination. And oftentimes that combination was that the first session was done in person and the follow-up sessions were done by phone. But however, we did have 40% who only did phone. And as you can imagine, many of them were from some of these outlying areas. And only 8% actually chose to come in for every session. And the number of sessions was flexible based on their needs, but it ranged somewhere between, I think it was like between 6 and 12 sessions that they met with a social worker on a weekly basis or bi-weekly basis, where they would spend about 45 minutes getting tools and coordinating their care. And just to show you that this kind of what kinds of things can be delivered via telehealth, these are the types of skills that people were taught, and kind of depending on their presenting problem, they may not have used or gotten all of them. But you can see by using the telephone and using this integrated care model, everybody 100% got psychoeducation, 100% were taught how to self-monitor pain and mood so that they could, self-monitor in order to then activate coping skills. Many received kind of exploration of values and tying that to their goals, goal setting, relaxation, and et cetera. So really a wide range of cognitive behavioral and educational treatment components can be delivered via telehealth. And just to highlight, I want to highlight a couple things. Again, these results are about to be or published on PCORI's website and about to be under review, but have been reviewed by PCORI. For our study participants, those who are assigned to MS care versus usual care had a statistically significant change in pain control at post-treatment, with 38% reporting that their pain was well controlled, again, using that outcome of a 30% or greater reduction in pain intensity. And 41% reported that their pain was well controlled at 6 months. So a lot of times we see this in our studies, that people who get better tend to stay better up to a year, as long as we follow them, 6 months to a year, once they've learned these behavioral skills. This is a busy slide. It just shows you that in addition to pain intensity, there were other measures that the telehealth combined in-person telehealth integrated care impacted, including pain interference, disability, and fatigue. So with that, we decided that although we found that we were having good reach and we were finding good outcomes in our research, doing one-on-one telephone care, I mean, obviously the world is moving to video conference. And so we decided to explore video conference delivery and group delivery because of the fact that if you do a group delivered behavioral intervention, people can learn from one another, and they can also, you can see more people at one time. So it's more cost effective potentially, and may allow more people to access care through groups. So we turn to the literature, and the idea again of video conference sessions in the behavioral realm is not all that unique, although there's still not that many studies published out there. I did find there was this systematic review that found that there were about 8 high to moderate quality studies in this review, and I think this review came out in about 2019. Group video conferencing has been studied for pain in rural Australia. It's been used for weight loss therapy interventions and for stress management post-cancer. And, kind of the trend, I mean, I think still this area is small enough that we need to be mindful that there's not a lot of data, but this analysis found that video conference appears to offer advantages over the phone and tends to be associated with, reasonably good outcomes. So I think it merits further consideration. So with that, then I'm going to just briefly tell you about a study that's ongoing called the ADAPT study. And this is where we use video conferencing to deliver mindfulness meditation and CBT together. And the ADAPT study is comparing mindfulness-based cognitive therapy and cognitive behavioral therapy for chronic pain in people with MS using group-delivered video conferencing. And it's 8 sessions of either the MBCT or mindfulness-based cognitive therapy or cognitive behavioral therapy. And we decided to add a usual care condition so we have that that control for people who don't get either of the interventions, although the usual care participants will be offered the opportunity to participate in either intervention at the end of their outcome assessments. And this is funded by the National MS Society. And if you want to learn more about this, there's a web address there, you can go to it. I want to talk more just about the telehealth component of this, because this study is still ongoing. We have no results. We haven't looked at them yet. But I want to tell you, in this one, we use the Zoom platform. We use the HIPAA UW Zoom account. In this study, we have manuals and workbooks that we share electronically as well as paper if people want them. Because it's a study, we have the luxury of doing some pre-treatment tech training where a research staff member will contact each participant and kind of talk them through how to use Zoom, how to set up everything so that when they're ready to start the group treatments, they're all set. Interestingly, we found that as time has gone on, since this study started pre-pandemic, since the pandemic, that tech training is taking a lot less time because people are just becoming much more comfortable with using video conference delivery. And then we also have weekly group supervision. Across all of our studies, we always have a supervision session where the investigators who are experts in the treatments and experts in telehealth, including myself, we supervise and consult with our study therapists who learn a lot from one another in addition to the investigators. And just to show you what it looks like, so this is not a treatment group. Obviously, I wouldn't want to share photos of patients, but this is our consultation group and my colleagues who I'll have pictures of later, but this is where we're doing our consultation supervision for our treatment sessions. And just shows you this is what our screens can look like when we're doing group therapy. You can have everybody, so you can see everybody at once typically. There's a lot of ways you can navigate the Zoom. So now I am going to present just a little bit of information about feasibility for this study, just some preliminary data, not by any kind of outcomes, but I wanted to share with you kind of where our participants are coming from and where they're coming from and how the telehealth piece seems to be going so far. And I have to admit, these data were pulled prior to, they were pulled in mid-February, I believe. And whoops. Let's see, sorry. I'm going to go back to that slide. Okay. So they've come from, I think it's 33 states. And I think since this slide was put together in mid-February, I think we have a few more states that we've hit. But one of the things we did, because we can recruit from wherever, the National MS Society posted an announcement and sent out an email about our study, and we were flooded with people. At one point we had, I think, 200 to 300 people. I think we had over 300 calls about people interested in this study, which I think alone speaks to the desire for people to have accessible pain care. Out of the 65 participants who had received treatment at the time that these data were pulled in mid-February, 77% had attended sessions had been attended. Only 2% were missed due to technology issues. When asked if they, at the end of treatment, if they would choose group video conference or something else, or prefer in person, 70% said they'd choose group video conference again, whereas 20 said they'd prefer in-person treatment. So certainly this isn't something that everyone enjoys, and I'm sure many of us would enjoy in person if it was more easily accessed. However, 86% are satisfied or highly satisfied with treatment. So these were the only kind of data that we looked at so far, and we'll see, I caution you, this is preliminary, but we're about halfway through, or we're actually over halfway through our sample. We're going to be enrolling 240, and we have well over, I think, half of that at this point, and we're just over 2 years into this study, so we will easily enroll our full sample. Again, I attribute that to telehealth. Ever since I started doing telehealth intervention studies, we've never not enrolled the number of people we wanted to enroll. So with that, I want to turn to our RRTC employment study specifically, which is part of the RRTC Employment and Disability, and really a partnership between my colleagues at the University of Washington and my collaborators at Shirley Ryan Ability Lab. And specifically, our study is called the ETIP study, or the Efficacy of Telehealth Pain Self-Management Intervention in Employed Adults with Physical Disabilities. And it's a randomized controlled trial. And the aims are to evaluate the efficacy of an evidence-based telehealth pain self-management intervention, ETIPS, and compare it to usual care in adults with physical disabilities who are employed. And the reason we selected to do this is that chronic pain is one of the biggest barriers that interferes with employment, both in terms of missed work, ability to work, as well as just kind of overall quality of life and satisfaction. So we decided to use an intervention I have not talked about today, but it's very similar to the Take Charge intervention. It's called TIPS, or Telephone Intervention for Pain Study. And we're going to examine it not only in terms of pain, but also other secondary outcomes, and evaluate treatment adherence and satisfaction barriers, facilitators of implementation. So it's a randomized parallel group trial. We're going to enroll 200 people who are employed with chronic pain and a range of disabilities, including TBI, spinal cord injury, and limb loss and MS. Let's see. Primary outcome is pain interference, or how much pain interferes, and a variety of secondary outcomes we'll look at, including vocational outcomes. And this one, like the TIPS and the Take Charge studies, it's 8 sessions delivered by telephone where they will learn pain self-management, but they'll learn how to address it in the context of employment. So they're going to learn how do you take that break when you're having a pain flare-up and practice a relaxation. I mean, a lot of what probably will need to happen for many people is, or what does happen, is that they have a lot of the changes they need to make are really self-care or self-accommodations, where they maybe have to remember to stand up every so often, or remember to do a pressure release, or a variety of things to help manage their pain. Like our other studies, this one will be using a therapist manual that guided by the therapist. And we have several therapists in this study who will be delivering the care. And there'll also be a participant workbook so people can follow along with it, but whether it be in paper or electronically. So that study has just gotten underway. We've enrolled our first few people. I think something like 3 or 4 people have been enrolled at the University of Washington, and we'll start enrolling at Shirley Ryan in the next couple months. And the treatment is being run, again, by telephone out of the University of Washington, but it's really a partnership between our 2 sites. And one of the things I want to mention is, given all of this Zoom, we really tossed around the idea of whether we should go with video conference versus telephone, but ultimately decided to stick to the telephone just because it's so much more accessible. And feedback we were getting from people who are working with pain is that it'd be a lot easier for them to step away, have a private conversation session versus to do it by phone or by video, sorry. So I want to conclude then by talking about just some best practices. And with that, I want to give the caveat that many of you are probably already doing telehealth. If you weren't before, I'm guessing you are doing it now. You've probably been trained at your institutions on how to do telemedicine. So I want to just highlight a few things we've learned from supervising, or I've learned from supervising people over the last 10 years delivering a wide variety of telehealth, especially pain, but also for other things. Just quickly, you know, certainly in Washington State, and I suspect at your institutions as well, you know, we need to provide, we have to provide people a patient education flyer describing it. When we are first on video, we have to show our badge, verify not only our patient's identity, but also our own. And we need to talk with them about how to contact us or how we'll contact them if technology issues arise. And this is just an example of our flyer that we use. So when we did our training, again, this was pre-pandemic, UW Medicine has some credentialing training that I went through and others would go through. And I mean, not to minimize it, I think it's important, but some of the positive behaviors they recommended, I thought, that are on this slide, I won't go through all of them in the interest of time, but you know, they listed some things that were really helpful. You know, things like leaning into the camera, nodding your head for encouragement, you know, having, making sure the patient at the site is secure, you know, making sure that you aren't tapping your pen and finger. I mean, lots of things, but I think these are really just a start. One of the things I've learned is not just being a good therapist does not necessarily make you, or a good clinician doesn't always make you a good telehealth or telemedicine therapist. It does take some training and some, you know, practice, and some just, it comes more easily for some than others. And I think one of the most important things I can recommend is that the first session is key, and to use common sense. So these are some of the things we do in our first session, which I think contributes to our high adherence rates. You know, we train people in the use of technology, as I described. We ask them to participate in a session from a safe, private place. We tell them we are going to treat this just like an in-person visit, and we ask that you do the same thing. We ask that you're in a private place, that you are only focused on the session, and that you kind of come prepared with your questions and with what you need to be doing. We also always make sure we have a plan for what to do if disconnected. And we just openly talk about some of the limits and challenges to privacy, and how we as a collaborative, you know, clinician and participant or patient are going to manage those. And then certainly having an emergency plan as a clinician is really key. And we can talk about that more later if it's of interest. But despite that, what I have found is, despite setting things up well and people being well-intended, we see a lot of privacy challenges that really require ongoing monitoring. So, you know, for example, one of our study therapists on our group treatment talked about how one of her patients had 2 kids, 2 babies that she was managing in the midst of a group session, and the babies were understandably not content to sit and participate in group therapy. So, you know, it can be challenging. Other times we've had people come in where people are bringing them a beer or things like that. You know, if for our evening groups. So there can be a lot of challenges, unintentional including. And so I think it's really important as a clinician to repeatedly discuss and troubleshoot and collaborate with your patients these challenges so that they see it as just part of the process of telehealth. Another thing that we've encountered a lot is this. 69% of Washington drivers use phones behind the wheel, a study found. Well, we find that some while participating in telehealth. Despite telling people from the outset that they should not and cannot be on a phone or on the internet while they're, while they're driving, they should not be driving, I'm sorry, they should not be driving while doing telehealth, we still find that as a problem. And we've had to develop protocols to the point where sometimes we've had to just simply tell people, we're gonna hang up until you get somewhere safe, and then we'll talk to you again. We use the technology to engage people. So we use worksheets, we show them on a screen, we can fill them out. There's all sorts of ways, depending on your platform, that you can, help people visually learn through telehealth. And this is just one example of something a therapist could fill out while you're talking with a participant. And here's another example of how it might look when it's filled out. This is just a thought record for cognitive therapy as part of a pain treatment. And by the way, I'll make my slides available to everyone should they want to see any of these in more detail. Just want to talk briefly about some challenges to group delivery, and then we'll be ready for some discussion. I think the group delivery in particular, the technology poses challenges. All of us have probably been in Zoom meetings where somebody either has noisy background, they don't mute themselves. We had one participant who thought he was muted but wasn't, but was talking about another member in the middle of a session, flushing a toilet. All sorts of things can happen. And certainly group members can unintentionally violate the privacy of others. We also have had to deal with the fact that sometimes people need caregivers. Somebody with a high level tetraplegia may not be able to, oftentimes they can with assistive technology, but sometimes they've needed some assistance. And so we've had to figure out how to incorporate them. It's just more challenging to manage remotely a group of people when you're doing treatment. So it's just something to be thoughtful about. As a result of our experience, and after we noticed that people were moving to telehealth for the pandemic, we put together some telehealth guidelines. This is just our group guidelines. We also have guidelines on one-on-one therapy. They'd really apply to a wide range of rehab interventions, and you can find them at this website address here, or I'm happy to send them out to people as well. And this is just an example table of the kinds of things that come up, that we go over in our telehealth telehealth guidelines. So in summary, I think telehealth care really involves accessible, effective care. It improves access. It's more flexible because it can work, especially, people who are working, it's going to be easier to work around their schedules and needs. It can be efficient because people don't have to spend time traveling to and from appointments. And I think the literature thus far suggests it's efficacious. So I think in conclusion, I like this image. This is a photo of people on game day for the University of Washington football team. This football stadium you can't see it. It's kind of as if you're taking this picture from the football stadium. And this is a picture of the variety of boats that some people take to get to the football game. And I like to think of that as a good analogy for telehealth. There's a lot of different ways you can get to a Husky football game. You can take light rail, you can take a car, you can walk, you can carpool, you can bicycle, you can take a variety of kinds of boats. Telehealth isn't necessarily meant to supplant everything. I think there's still going to be a need for in-person care, but I do see it as one really accessible option for helping people get evidence-based pain care. So with that, I'm just going to flash up some acknowledgements that we could probably start talking. I want to acknowledge Neidler for funding of our project and for the lecture today. My collaborators on the RRTC, many of these are familiar faces to all of you. And importantly, my colleagues who have worked with me at the University of Washington. We have some of my faculty colleagues, our postdoctoral fellow colleagues who are some of our very skilled therapists. and also our research team, including, I want to highlight Carolyn Green, who is study coordinator for the ETIP study, and really instrumental in this project. So thank you.
Great. Thank you so much, Dawn. For those who are would like to engage in conversation, please feel free to unmute yourself. I would like to start. There were several comments in the chat box, so thank you all for engaging there. Dr. Pons might have to leave early, but he started a really interesting conversation about whether or not the digital healthcare innovations that have been occurring post-COVID, whether you think these are something that will stick around.
I do think so, for several reasons. I think that, I think we're all becoming familiar. I mean, it was interesting. For the last, 5, 6 years, I've been talking to provider organizations and rehab providers, including some of my colleagues. And really, I kind of would run up against resistance to the use of telehealth. And I think, unfortunately or fortunately, the pandemic has really accelerated people's acceptance of it. And I do know that within our system, I think there's some talk that will probably become part of one of our options. And the other thing is, I do some work with our Washington State Department of Workers' Compensation, and they're really looking at whether they might continue to fund telehealth after the pandemic for a variety of injured worker services. So I think kind of it's like, it's out of the bag, so I do think it's going to continue. And I think what we need to learn is like what kinds of care are well suited for telehealth or telemedicine, what kinds of things are better suited for in-person, and there may be combinations that make sense too.
That brings up another question that Chris Gagnon asked in the chat box. I think in your ETIPS program, it's mostly a telephone-based intervention, and telephone-based treatment excludes the potential benefits of visual cues, facial expressions, and things like that for both the patient and the clinician. Has that been explored in your particular work, or just in general, comparing it to what, because now so many people are getting used to Zoom and video interactions?
Yeah, it's interesting because David Moore did a study comparing in-person CBT to telephone delivered CBT and did not find any significant differences in rapport or in outcomes in general. So, it's interesting though, as a clinician, I like seeing people's faces, although now I do see some patients in clinic now, and we're 6 feet apart and I have a mask on and they have a mask on. And I find that, having to overcome that, but over time you do. I do think probably it makes some sense to move to video more, but I think there are always going to be those people who it just isn't as easy for people, at least current technology. Or like I said, for our ETIP study, it might be that they're not in a space that visually they can share where they're at for whatever reason. Maybe they're sitting in their car. So a telephone is going to be a lot more accessible.
Another question that I have to follow up on some of the kind of the future of this is whether or not, Dawn, have you explored, or also just to open this up to other people in the audience that were commenting in the box, the cost benefit analysis of doing the telephone intervention? Because one of the things that we're noticing in the real world is that although at least now we're getting reimbursed for telehealth, which we previously haven't been, so that's kind of an amazing advancement. Most of the policies have been written to go away at the end of the pandemic or whenever things settle down. That might be a long time, but do you think that reduced reimbursement rates for the phone interaction or video interaction are sustainable?
Boy, that's probably a bit out of my expertise. I think it's going to vary by state to state and payer to payer. In Washington State, the telehealth parity law does not allow reimbursement to be different for telehealth versus in-person care. So in our state, there's less incentive to move back to in-person care because rates are the same, at least currently. Who knows where they'll head, right? I think it speaks to the need. I'd be curious what other people think. I do think it speaks to the need for us to be doing research to really look at the cost benefit and efficacy and real world, in particular, real world effectiveness, because I think this is a natural experiment that we're all participating in. And if we can learn from that, maybe that will influence payment to ultimately, the goal in my eyes is really just to have good quality care. And that may include, I hope that includes telehealth or telemedicine as well as in-person care. So I don't know if others have thoughts on that in the group.
I have one other question I'll bring up from the chat, but feel free, please, those of you who are still muted, feel free to unmute. Dr. Lieber earlier in the talk asked whether any of your studies took into account the technical competence of the participants. In other words, is there a baseline level of competence that's even required in the first place for telehealth? Later, you mentioned that you noticed the tech checks were getting faster as participants might be getting more accustomed to the technology, but what do you think about the technological competence baseline requirement?
That's an interesting question because we didn't assess that in any way, but I would wonder about that. Certainly, certainly we tried to design it so that anyone, including people with cognitive impairment, could participate, because we feel strongly that people with cognitive impairment or other physical impairments should be able to participate. So we tried to make it adjust it to the level of the person we were working with. But that would be a really interesting question to see, if they they're tech savvy at the beginning, how they do.
A follow-up question on that, Leora Cherney also said that they found it very time consuming and therefore it's costly to get the group participants trained and comfortable with Zoom in the first place. I know that you're using the telephone interventions. Do you have any, and I'm sure that you now have lots of experience with Zoom as well, do you have any tips from your training sessions that you've done with group participants on ways to make it less costly?
Yeah, we have the luxury of being in a research study, so our tech training is occurring for free, right? It's not costing the clinicians. I mean, it's part of the study costs, but we have developed some pretty simple instructions that we share with them, and I think as time goes on, it's going to be easier and easier and be less costly. I mean, we're noticing that already, that it's some of our participants no longer need to have the Zoom video conference training, or they say, nope, I know how to use it and that's it. So, I think that is a potential barrier to clinicians, and I think that payers ultimately, ideally, would take that into account. But I also think that, there might be ways to have administrative help to set up groups in the long run. Kind of like we have our research assistant help us set up our video groups. So.
Yeah, that's a really good point. Pam Cropero added to the chat box whether any of the services at University of Washington were reimbursed by the state of Washington itself, for example, vocational rehabilitation.
Certainly our labor and industries, or workers' comp in the state of Washington, is reimbursing both telephone and video care. And they are doing it at the same rate as they do for in-person care. Whether our Department of Voc Rehab is reimbursing, I'm less certain of. I don't know if Kurt or Mark are on the call, they would maybe know, but I'm not as certain about that. It seems to me in our landscape out here is that if it's covered by in-person, it's being covered by all payers. But I don't know, is that the case in Illinois?
I'm actually not sure. I know that we are delivering, and I believe in Illinois that we have a similar rule about some reimbursement rates from some payers have to have parity, but I don't think it's all payers, and I'm not sure. I see BT on the call, who's one of our vocational rehabilitation counselors at the Shirley Ryan Ability Lab. Just to throw him under the bus, I don't know if he can answer.
Well, as far as I know, the Illinois Division of Rehabilitation Services are reimbursing the vocational rehab stuff for doing like telehealth with our current clients. Now, this may just be during the COVID-19 precautions, but I believe we're getting reimbursed by the state.
That's great to hear.
Great.
So I've noticed the time now, it's just after 1 o'clock. So I wanted to just make sure I close with a special thank you to Dr. Ehde for her great presentation. It was a very timely topic, as people in the chat box noted. So thank you very much for that. And thank you to Linda Ehrlich-Jones and Alan Heineman for their support of this lecture. do a part of their employment study for people with physical disabilities for their center. So thank you all. I'll keep the line open for a few minutes if there are any lingering comments as people are leaving the room. But if not, thank you all for attending today.